Okay, so part two. Now, we've talked about fast acting ionotropic receptors that allow negative or positively charged ions in, make the cell more likely or less likely to fire. Other cell receptor types will trigger these slower acting processes. So sometimes when we activate a receptor, we cause, say, cell growth. We cause a process to occur inside of the cell. This is actually a photomicrograph of neurons reaching out and connecting to each other, which is really quite phenomenal that we can actually see this with our eyes. So a couple of different types of receptors that we're going to think about here. One is a family known as G protein coupled receptors. And there are a number of different kinds of neurotransmitters that will work, that will have receptors that are G protein coupled receptors. So you'll hear this said sometimes they're abbreviated GPCRs. But what these are doing, so this red dot here represents a neurotransmitter. Once it attaches to a receptor, there's this G protein that moves and causes a sequence of changes inside of the cell. So we can think of this as kind of a chain reaction that has begun by having either a drug or a neurotransmitter attached to this receptor that is outside of the cell. So example, this would be many serotonin receptors like the serotonin 2A receptor. You can also have intracellular receptors. So you can see the red dot here now is attaching to a receptor that is outside the nucleus. And this is going to affect things like transcription in the cell body. So these are slower acting receptor types. They don't have that fast, immediate effect that the ionotropic ion channel type receptors do. And so when we talk about these kind of receptors, we're often talking about what kind of activity do they have once they attach to the cell? So, or the cell receptor rather. So the receptor can either be turned all the way on, which is known as an agonist or an activation. It can be sort of prevented from being activated by the endogenous neurotransmitter. So this would be an antagonist. And we might think about this as like, when you put those little plastic covers over your electrical outlets when you have small children in the house, it's not turning off the electricity, but it's preventing anything from connecting with that receptor. So that would be an antagonist. Or we can get that receptor activity to stop altogether. And this would be an inverse agonist. I've already talked about positive and negative allosteric modulators, but those work in tandem with an existing ligand for that receptor type. And let's give some examples of different kinds of drugs and how they interact with these neurotransmitter systems. The first one is pretty straightforward. This is to cause a direct release of a neurotransmitter. A good example of this would be amphetamine, which causes dopamine to be pushed out into the into the synapse from the presynaptic neuron. Another would be MDMA, which causes largely serotonin to be pushed out from the presynaptic neuron into the synapse. We can also have drugs that essentially mimic the effect of a endogenous ligand. So these would be exogenous because they're drugs. And so they're coming from outside the body, but they attach to a receptor in the same way that a neurotransmitter might do. So an example of this might be like morphine on the mu opioid receptors attaches to that receptor in much the same way that the brain's own endogenous opioid system, or endorphins, if you will, would attach to that receptor. We can have allosteric modulation, as I mentioned before, which causes that receptor to be less or more likely to activate in the presence of its own endogenous ligand. We also have those antagonists. So again, that's sort of like the childproof cover on the electrical outlet. So in this case, haloperidol blocks dopamine receptors, prevents them from being activated by the body's own dopamine. We have autoreceptor antagonists. Now, this got to kind of wrap your head around a little bit. Think about autoreceptors as like the thermostat in your house. So if you think about the relationship between your thermostat and your heater doesn't really understand what 68 degrees means, but the thermostat does. All the heater knows how to do is to make heat. In much the same way, all the presynaptic neuron knows how to do is to release neurotransmitters. However, the autoreceptor is sensitive for those neurotransmitters that are being released. So when enough neurotransmitters is released, some of it's going to float back up to the autoreceptor. It's going to attach to that autoreceptor, and it's going to tell the presynaptic neuron, hey, you can hold off now. You don't need to release any more neurotransmitter. So you can imagine if we block that receptor, we prevent it from being activated by those neurotransmitters that are floating around in the synapse, we can trick the presynaptic neuron into continuing to release that neurotransmitter, and that can be used therapeutically. So, for example, we do that with mirtazapine. We can also block or inhibit or slow down the transporter pump, sometimes known as the reuptake pump, for various monoamines such as serotonin, as we do with an SSRI, with norepinephrine, as we do with, say, bupropion, which is a norepinephrine reuptake inhibitor, or with dopamine. We can inhibit that reuptake, or also sometimes known as a transporter. We can also inhibit the enzymes that break down neurotransmitters. So the first antidepressants were monoamine oxidase inhibitors, or MAOIs. That is the enzyme that breaks down the monoamines, which that be like serotonin, norepinephrine, dopamine, and histamine. Those are all broken down by MAO. So by inhibiting that, we allow those neurotransmitters to hang out in the cell, in the synapse longer, and be more likely to hit the receptor on the other side. And then finally, we can inhibit the repackaging of these neurotransmitters back into synapses. So that VMAT stands for vesicular monoamine transporter. So it's moving the neurotransmitters back into vesicles where they're packaged back up and reused again. So we can target that as we do with certain drugs that we use to treat tardive dyskinesia, known as VMAT2 inhibitors. So let's talk about the activity of a drug on its target. So, sometimes we throw this term of like potency, like this is a very potent drug, or this is a very strong drug. What exactly does that mean? And to introduce this idea, I want to introduce you to a brand new drug called homersimsamine. So homersimsamine, before it can do anything, it has to get to its target. So the first question is, can it actually attach to the thing it's trying to get to? And this would be known as affinity. So if it just floats past the place where we'd like it to stick, it has low affinity. But if it quickly attaches to that receptor, we can think of this as a drug that has high affinity. Next, once it attaches to that receptor, what does it actually do once it's attached? And this we can think of as potency. If it causes a lot of activity, that drug would be very potent. If it only causes a little bit of activity, we would say it's a less potent drug. And this affinity of a drug, or we can think of it as a kind of a stickiness for the receptor, is known as this is measured in something called Ki, which stands for inhibitory constant. And this is one of those numbers that's kind of flipped around. So the lower your Ki, you can think of that as being more sticky on that ligand than another drug that has a higher Ki. And sometimes when a drug competitively binds for the same site, we can actually use this strategically. So for example, naloxone or Narcan has a lower Ki than morphine. So if somebody is overdosed on morphine, we can use naloxone. It will go to those same mu opioid receptors and say, hey, get out of my way. I'm going to sit there now. And that will turn off that activation of that mu opioid receptor, which is causing the overdose symptoms, and will allow that receptor to return to normal activity. Now, naloxone, of course, has a very short half-life. So sometimes if the person has overdosed on a long-acting opioid, we might have to give it multiple times because the naloxone is going to wear off it's going to be metabolized, and that opioid is going to move right back into that receptor. But this is how naloxone works. And often, if a drug has a low Ki, we often can get away with using less of it than a drug that has a high Ki, which is less sticky on that receptor. So another way you can think of this affinity for the receptor is like these two seats here. So the drug that has high binding affinity is like this guy in the lazy boy chair who, dang, he looks happy. But he's not going anywhere. So that we can think of like haloperidol on the dopamine receptor. It's sitting on there and it's not getting anywhere. It's not getting up and it's not going anywhere. Now, a drug that has lower binding affinity for the D2 receptor would be quetiapine or Seroquel. This is a drug that's going to come by that receptor, which is represented by the bus seat here. It's going to sit down for a few minutes, and then it's going to get up and move along when the bus comes along. It's not going to stick around very long. Nobody sits all day like this lazy boy guy on a bus seat if you can help it. So this is a drug, quetiapine, that has low binding affinity for that D2 receptor. And we can quantify this. And this is a useful way of looking at comparing different kinds of drugs, which help us know how potent is it for the receptor activity that we do want. And we can also start to look at how might this drug cause problems? What sort of side effects might this cause? So in the interest of being able to read this very small slide, I've highlighted the key places I want you to look at. So D2 is important in the treatment of psychotic symptoms. The M stands for muscarinic acetylcholine receptors, and H stands for histamine. So let's take a look at some different compounds here. So haloperidol, as I mentioned, has a low Ki, 1.4. So it is quite sticky on that D2 receptor, which is one of the reasons why it's a very effective antipsychotic. Compare that to quetiapine. Quetiapine's Ki on the D2 receptor is 310, so many-fold less. So it has much less stickiness on that receptor. Now let's take a look at the acetylcholine muscarinic site. So so if we look at haloperidol, for example, you'll see that it has very little affinity, almost 5. So it's at 5,000, which is essentially means it has almost no affinity for that muscarinic acetylcholine receptor. Now, if you've worked in inpatient psychiatry or in emergency psychiatry, you may be familiar with this practice of giving haloperidol co-prescribed with an anticholinergic drug, a drug that's going to block that muscarinic acetylcholine receptor. And we do that to reduce some of the movement type side effects that can happen from a strong dopamine blockade, such as restlessness or even dystonias. Now, when we pay attention to the histamine receptor, that matters because this is something that's going to not only contribute to weight gain, but also sedation. So let's take a look at a couple of different drugs. I'm not sure if I started this one here, but let's go across from olanzapine here. Olanzapine has a Ki on that histamine receptor of 2.2. So it's quite sticky on the histamine receptor. This is going to make a significant contribution to the sedating effects of olanzapine. We compare that to a different drug, aripiprazole, usually thought to be less weight, less of a problem with weight. And that makes sense. It's also less sedating because its Ki on the histamine receptor is 25. So by looking at these sorts of things, we can start to predict what sort of effects the drug is going to have, both the desired effects and the side effects. Another idea to put into your thinking here is known as the inhibitory or excitatory constant 50. What that means is how much of a drug do we need to inhibit a biological process by 50%? So let's take an example like inhibiting the transporter for serotonin, also known as the reuptake pump. So how much of a SSRI do we need to inhibit that pump activity by 50%, or to block the activity of a receptor by 50%? So when we take all this together, both the Ki, which is this middle section here, and the functional potency, how much does it inhibit the activity of a biologic process. We can take a drug like vortioxetine, so this is Trintellix, and we can take a look, and without having to go through all these numbers, this is summarized here at the bottom. So the place where it is most stickiness is on the serotonin transporter, and then these other serotonin receptors. And then the process which it inhibits the most is the serotonin transporter. So this has largely SSRI-like effects, which it does. Which makes sense because that's its primary affinity, and also it's the main thing that it inhibits. But it also has activity on these other receptor types, which is what makes vortioxetine kind of an interesting drug. Now, what does it do when it gets to the receptor? The options here would be that it either blocks the receptor, so it prevents that receptor from being activated by endogenous neurotransmitters. It doesn't turn it off altogether, right? So that receptor will always have a certain amount of activity unless it's attached to an inverse agonist, which I'll talk about in a second. So sometimes people think that if you attach an antagonist to a receptor, you get no activity. That's not true. What you don't get is activation from the other neurotransmitters that are trying to attach to that, because you've put this cover over it, like the childproof covering. Now, you can also activate a receptor. You can activate it partially, which would give you some activation. You can think of this as sort of like a dimmer switch. So this dimmer switch is partway on, or we can turn it on all the way. We can allow the full current, if you will, to flow through there. So this is a full activation of a receptor with an agonist. You can go the other way too. You can turn the lights down further down. That would be a partial antagonist. So you're blocking it not entirely, but part of the way. Or you can have an inverse agonist, which is kind of, it took me a long time to understand inverse agonists. But what inverse agonists are doing is that they are stopping all activity of that receptor. So we can think of this in a different way like this. So if we think of this like a metronome. So our normal firing rate might be like, okay, that's the normal firing rate. We throw a full agonist in there. So now we've turned that up all the way. So now we got that. All right. A partial agonist might be somewhere in between the two. Okay. An antagonist, because it's not being activated by the endogenous neurotransmitter, it's still firing, but it's not firing as quickly. Now, the inverse agonist, not firing at all. So this combination of stickiness or affinity, the type of activity on the cell, whether it turns the receptor on all the way, or if it stops that activity altogether, or if it just prevents it from being activated by neurotransmitters, plus the amount of drug that we need to inhibit or excite a process by 50%, all comes together to equal drug activity. Now, you might be thinking like, well, wait a second. I know, for example, that if I take an SSRI, within 24 hours, I am slowing down the activity of that serotonin transporter. Why is it that it takes many weeks for me to feel better? Okay, so that happens within 24 hours. So why would that be? And the short answer is that while we are changing activity on the outside of the cell, we're influencing activity on the inside of the cell, and that process can take quite a bit of time. So a real gross oversimplification of this would be this idea of how an SSRI works. So there's this misnomer that we get depressed because we don't have enough serotonin. That would be like saying we get headaches because we don't have enough aspirin in our body. Now, we can certainly treat a headache with aspirin, right? We know that works, but it's not a deficiency of aspirin that causes a headache. Similarly, we can treat depression by increasing the amount of serotonin, but it's not a deficiency of serotonin that results in depression. So let's walk through this. So we start taking an SSRI. We've blocked that transporter, that reuptake pump, as you see there. Okay, so we've got more serotonin floating around in the synapse, more likely to get over to the other side. This is the first messenger. So connecting serotonin to that serotonin receptor is going to be the first messenger. Then multiple things are going to happen downstream. I'm not going to belabor the point here, but inside that postsynaptic cell, there's going to be secondary, tertiary, quaternary messengers that all happen. One of them is going to be the release of something called brain-derived neurotrophic factor, BDNF. You can think of this as like neuronal fertilizer. And this is going to act on something called TRK-B receptors that are inside of the cell, inside of the neuron. And that's going to have an effect on genetic expression, which is ultimately going to cause increased neuronal growth. So we can think of this as a slow moving neuroplastic activity. So this is many ways down the line. So here is the neuron, the dendrites, the branching, if you will, of a neuron. You see those little red buds? Those would be like our little leaf buds in early spring. But then we add this antidepressant, if you will, this serotonin, this thing that's going to cause more serotonin to be available. Okay, that's going to cause this secondary messenger to be activated further down the line, finally acting on the genetics of this cell, and we get this change in growth, this neuroplastic kind of event. And we see these little red buds popping out just like a happy tree in the springtime. And we know this from human positron emission topography scans. It's tricky to do this kind of work in humans because obviously you can't just take a punch biopsy of somebody's brain before and after they are exposed to an antidepressant. So we have to use these indirect methods. And in this case, you give people a radio tracer. You inject them with a radio tracer that's going to attach to a structure that is the thing you want to study. You scan the person's brain, and you can see where those radio tracers have stuck to. And what in this study, what they did is they gave patients either escitalopram, 20 milligrams, that's Lexapro, or they gave them a placebo. And then after 3 to 5 weeks, they stuck them in the PET scanner. And what you see on the right here is that the group that got escitalopram had, on average, more of this dendritic growth in areas such as the hippocampus and the wrinkly part of the brain, the neocortex, compared to the group in the darker color here, which got the placebo. So this is evidence that what we're actually doing when we give somebody an antidepressant is inducing neuroplasticity, albeit slow moving neuroplasticity. And I think with that, we can go ahead and wrap up here. And I look forward to looking at your questions and comments in the discussion. So thank you for your attention.